I am actually here as a fill-in. Our Jennifer Pelster, who is our former coordinator for the Mandan Good Neighbor Project, just moved to Nebraska. So I do not have a PowerPoint today. I am just going to be talking about our syringe exchange program, the Mandan Good Neighbor Project, and we are located in a facility. So we're located in Custer Health, which is a local public health unit. So as I go along, I like this to be very casual. So if you have questions, please stop me because I tend to speak fast. So if you have questions, please let me know. We were the first syringe exchange harm reduction program in North Dakota. We opened in January of 2018, and currently we have 405 enrollees. Out of those 405 enrollees, 3 are HIV positive and 55% are hepatitis C positive. And we do draw HIV and hepatitis C on enrollment and then every 6 to 12 months while they're in our program. And we're able to do that at our health unit. Yep, go ahead.
So I was going to say, so Jody, can you, as part of this, you might be covering it, but so what does it mean to be an enrollee? What is the process for that? And what is kind of requirements or any of that? What does that mean to be an enrollee?
Sure. So our program is anonymous. So when somebody comes to our program, we assign them an ID number, and it has letters and numbers in it. So they get assigned an ID number. There are some questionnaires to fill out. We have certain things that we need to report to the state through our plan that we have with the Department of Health and Human Services. So we have to get all that criteria. So every time they come in, they have to answer a few questions. Just talking about what they're using, how they're using, are they sharing? And then that also brings up opportunity for us to work in the harm reduction piece, to talk about not sharing. Also, are they homeless? Do they couch surf? Are they using sex to get their drugs? So all those types of things we ask so we can work on the harm reduction piece. So we can give them condoms. We can talk about safe sex. We can, give them immunizations. So that's another thing, being in a public health agency, we can also provide immunizations on the spot. So all those things are a whole part of that enrollment process. And then every time they come in, they have an ID card, and we do laminate that ID card. So I'm not saying that they don't lose it, but it's just so they have it each time they come in so we can identify them. And we have certain nurses that are trained to work in that program. So those nurses get to know their clients quite well. Right now, we are providing services Thursday afternoons from 1 to 4. We normally provide services Tuesdays and Thursdays from 1 to 4, but I am short 2 nursing staff. And actually, I have one of our new staff with me right now. Gail is with me today. She is going to be starting the Mandan Good Neighbor Project also. So I thought it'd be great for her to hear about the Fargo CAS program also. So right now, Thursday afternoons, 1 to 4, I have 2 nurses that work. We try to get as many through as we possibly can, but we are not taking any new enrollees right now. The new enrollment process does take about an hour, so it is a little bit more intense. Once they come back, they do need to bring us used syringes for us to give them new syringes. So that is part of our program. It's a 1+1 program. We also have Face It Together here, which is peer-to-peer counseling. So they are here every time we are doing our syringe exchange harm reduction program, and they can help our clients with substance abuse treatment. They can get them connected to things like housing. They can help them with a phone if they don't have a phone, transportation. So it's just a wonderful way for them to establish a rapport with our clients, and then hopefully when they're ready to go into treatment, they can work with Face It Together. Also, every 2 weeks, our clients come every 2 weeks, and at that time, they are given 40 syringes. So we are we do have some limits to what we can give, which is unfortunate, but it's how our plan is written and it's the funding that we have. They also get fentanyl strips. We give naloxone. Most of the time we do the IM for our syringe exchange clients because they are very, they know how to draw up, they know how to give. If they do not feel comfortable or they have a family member that wants to be trained, we do have nasal Narcan that we can use to train them. We provide them with cookers, filters, alcohol swabs, hand sanitizer, sterile water to cook their drugs, tourniquets, bio buckets. Like I said, we do have immunizations available if they are needing immunizations. And then we also provide those resources for if they need food, housing, work. Either our nurses are able to do that or we send them to Face It Together so they can work with them. We do have a kiosk also that we have in Mandan, and we also have a kiosk in Beulah, North Dakota. Custer Health serves 5 counties. So we tried to start a syringe service program, a harm reduction program in Beulah, did not have any enrollees in 6 months. So we closed the program there. And I think part of that is it's a small community, and I don't think people felt comfortable, coming to syringe exchange in a small community. Our location here in Mandan is on the south side of Mandan. We're actually in a strip mall. So it is, you could be coming here for WIC, immunizations, car seats, I mean, numerous different things. So you can stay fairly anonymous if you're coming in for syringe exchange. And we have a really good relationship with the Mandan Police Department. They do not target our clients. It's really nice. If I see a police officer going around the building a couple times, I usually call the deputy and say, what's going on? And then they will back off. It's usually not anything to do with our syringe exchange program, but it does intimidate our clients, and we like to keep that trust there. So we do try to not have police presence. So our kiosk here in Mandan is not used for our syringe exchange program. It is used for the community. So anybody in the community can put use syringes, so like diabetic supplies, lots of those types of things. So as of October, we had 766 pounds of biohazard waste that it was picked up. We have a service called HESI out of Fargo that does pick up our biohazard waste. And they just picked up 2 more boxes. So I'm sure we're going to be over 800 pounds of biohazard waste from the community. So that is all I really have. One thing I forgot to tell you was people have to be over the age of 18. We do not see anybody under the age of 18. So over the age of 18, we have standing orders in place from our medical directors. So the things that we do have a medical director that leads us. And how we got started, the nurse that just left us, shame on her, she pushed me and pushed me and pushed me and kept saying, we need harm reduction. We need a syringe exchange program. And I said, it's really hard to take that to our board of health, without a lot of statistics. So we were fortunate to have an intern that now works for the Department of Health and Human Services that did a study for us on hepatitis C cases and where those cases were linked. And we were seeing that it was linked to IV drug use. And so that pushed me to say, okay, yeah, we have a problem here in our counties and we need to move forward. So then I had to take it to our board of health, and that really made me sweat a little bit because I did not know how our board of health was going to accept this. But we have a dentist on our board of health and we have a physician on our board of health, and they both said, yes, we need this. So then you have to get the community on board, which was a little bit harder. And we still, have community members that are not as happy with this program. But so it's a process. And Robin will tell you that too. It is a process to get things set up and moving forward. But 405 enrollees, that's a lot of people that are enrolled, and they're from all over the state. We also see people from South Dakota, Montana, Minnesota. Any questions?
There was a question in the chat regarding where referrals come from. So do you get referrals from addiction counselors, or how do clients find out about the program? What promotion are you doing?
We do a lot of social media promotion, and that's kind of how we also connect with our clients, because during the storm we had to close a couple days. So that's where they look. They look at Facebook. We also have a website that we try to keep up to date with all of our hours, and if there are changes. Referrals are self-referral. A lot of times somebody that's in our program will grab somebody else and bring them. We'll have a group of 5 that travel together because transportation sometimes is a problem. We do have a bus stop really close to our facility. So a lot of times they will come on the bus, which is great. We do get referrals from addiction counselors. That hasn't been as many as I thought we would see, but we have literally had addiction counselors bring clients to us. So we do like that. It's great because we're all working toward the same end result.
Okay, great. And then Teresa with Valley City asked, how many participants are there on the average day? So you quoted the 400 number of total, but on an average day, how are things?
It varies, usually about 25 to 30 each time that we have a syringe exchange day. So I have a feeling we're going to really be inundated now that we have switched to 1 day a week instead of the 2 days. Until I can get nurses up and trained, we're going to not be taking new referrals, which is unfortunate. We have to turn those away. But yeah, right around that 25 is about the norm. And they come and go. I will tell you, we haven't seen a client for a year. They come back in and you're like, where have you been? And either they've moved or they've been incarcerated, or, there's just lots of different reasons. But our nurses do get to know their clients, and they do worry about them also. They'll say, this person hasn't been in for a long time. I'm worried. So yeah, you do establish a relationship and a rapport.
I was kind of wondering that when you mentioned the large catchment area you have. One, Custer Health does just have a large catchment area to begin with. So even though you're located in Mandan, but when you mentioned like Montana, South Dakota, how frequently those individuals, are coming in. And so then I would think that you would have people that are kind of your regulars, but then also people that, as you said, come and go that you don't see for a while.
That is correct. That is correct.
So it's good that service is available. So another question, is there an agreement that you offer your client that assures them that their identity is safe and free from legal retribution? Apologies if this was mentioned previously.
Yes, we do. And we also have we call it our rights responsibilities. So we, are very open with them that they have to do certain things, we will do certain things, and part of that is to keep their identity anonymous.
There was a question by Jill follow-up. She asked, can you share this agreement? So if that agreement is something that's shared.
Sure.
So
yep, I can share that. Should I send it to you, Rebecca, or Jennifer, or?
Yeah, you can send it to me and I can send it on. That would be fine. I can send it on with the materials I send out after the session. So any other questions for Jody? Now we are going to turn it over to Jordan with Fargo.
Hello, everybody. How's everybody doing today? I am Jordan Byer. I am the harm reduction specialist for Fargo Cass Public Health. Today, I'll be speaking a little bit about meeting people where they're at when it comes to harm reduction. So a couple of things I'll touch on are street outreach, I'll touch on some housing support stuff, and then I'll touch on some work that we've done here at the SSP. So some of the things you're going to learn today are, like I'd mentioned earlier, about meeting people where they're at. So some examples I can give, I'll do that a little bit later, but one of the things is, so meeting people where they're at is a pillar of harm reduction. It does call for non-judgmental, non-coercive provision of services and resources to people who use drugs, right? In the communities that they are in, that's the meeting people where they are at aspect of it. The actual definition of meeting people where they're at is meeting someone where they are means bridging the gap between your own expectations and where the other person is coming from. That can mean intentionally listening. That can mean to understand their values, their needs, desires, and even their trauma responses. I do feel like this is a skill that everybody should learn. It's not only their physical, actual place they're at, but that is where they're at mentally and emotionally. I think that's a lot of things. There's a lot of things that we can keep in consideration when meeting people where they're at. I do have a little picture on a slide that obviously you guys can't see, but it's a picture of Winnie the Pooh and Piglet. And he says, you can't stay in your corner of the forest waiting for others to come to you. Sometimes you have to go to them. I think that really speaks on what we're talking about, right? So for the street outreach side of it, bringing the services to where people are, whether that is a parking garage, whether it is under a bridge, whether it is going to an encampment by the river, these people that we're going to reach typically won't come into your office or your service site until you build rapport, build some trust with them. That's when you can really start getting people in the door. But the groundwork really does start out on the street and meeting people, like I said, at their camp, under a bridge, in a parking garage, wherever they're existing in that moment. So some examples I can talk about when we did some street outreach and we were meeting people where they're at. We had a gentleman, he was an older guy. He was really hesitant on going into shelters. He had worked in a homeless shelter in Minneapolis for years prior to coming to Fargo and being homeless. For a very long time, he had a wall up, and it was really difficult to get to him, really difficult to kind of even really talk to him about anything. He just wanted to mind his own business, leave me alone, I don't want to hear it kind of guy. But after a few months of that, we were able to complete his housing prioritization tool. It was literally at a gazebo down by the river. We met him there right next to his camp, got it done. A couple months later, he ended up moving into housing. As you guys know, North Dakota in the wintertime, it gets a little cold. And this is one of those guys that he refused to come into shelters. So after doing some outreach, after doing some stuff to try to get him where he wanted to be, he did end up coming into the shelter. And I think a lot of that had to do with building that relationship, building rapport with him, letting him know that there are people out there that care and that he can trust. But we really just want to get him in whatever position is best for him. It's the one thing about meeting people where they're at. It's not your idea of how the way things should be. We're here to support folks in whatever changes they want to make that are beneficial to their lives. If we move on to some housing support style side of it, I do have a couple quotes here. One of them is, listen to your clients and respond to their needs and goals rather than imposing a service you think that they need. The thought of, if we build it, they will come, is insufficient. Rather, we need to work with the stakeholders, the clients, and the community to ensure that we're providing services that are relevant and accessible to those in need. A couple examples, I'll go over that in a second, but for housing supports, if you think about folks moving out of a shelter into their own apartment, meeting them where they're at, and we can talk about the gentleman that we did get in the housing. So moving from a congregate setting like a shelter, or we'll talk about a shelter, in reality, you have like 30 roommates every day. So in the shelters I've worked in, they're typically a dorm setting. There's about 20 to 30 gentlemen in bunk beds all in one room. So going from that to going to your own apartment can be really scary. It's empty, it's quiet, it's lonely. One of the things that we did here at the Harm Reduction Center, our SSP here in Fargo, is we had for a while kind of a little thrift area. So when folks would move out of the shelter and they'd move into their own apartment, we would try to give them everything that they would need in that moment to feel comfortable in their own home. What we found is that if we would just move someone into an apartment and there wasn't really supports in place, typically they would go back to the behaviors that kind of led them down the path that they didn't want to be down anyway. Whether that would be going back downtown, hanging out on Broadway, drinking in public, kind of getting back with the crowd that they were hanging with before that they were kind of getting in trouble in. So being able to support them in their home and make them feel like it is their home. Over here, we had decorations. We had a whole room full of kitchen gadgets and cutlery and towels and DVDs. Well, that was one of the things that I think we really take for granted as folks that aren't struggling with homelessness, is just the quiet of it. And even just having a DVD on in the background can really help somebody stay in their own home and stay comfortably and being able to work towards whatever goals that they have. And being someone that is going to support that person in housing, that's really what we're there for. We're kind of a co-pilot for their life. At the end of the day, this is their journey. We're just there to help guide them. If we have anything that we can do for them, sometimes they're just going to not want to deal with you. And that's okay. We're supposed to be there when they need us, not go to them when we want them to need us. Housing supports can help bridge the gap between the streets and living happily in your own home. I think not projecting how you think they should exist in their own home, but being supportive to their positive changes is crucial. I know a lot of us, we can have preconceived notions of, well, why don't you do this? Why aren't you doing this or going about it this way? And at the end of the day, it's their choice. It's their home. It's their life. And I think just being there for them and being that supportive person is huge. One of the quotes I have is, Dan says he is grateful, and even if he does face challenges down the road, I have a home base where I can handle them from. And I think that's huge. That's one of the 3 homes, right? You need to feel comfortable in not only your body, but you need to feel comfortable in the place, your dwelling that you're living in, and then in your community. And I think feeling really comfortable in yourself and in your dwelling is huge for people to become a productive part of society. If you don't feel good in those aspects of your life, you're not going to care about your neighbors. You're not going to care about the community around you. But once you can build that foundation, you can build a way to be the person you want to be. All it takes sometimes is a little bit of support from people that care. So I think recognizing that homelessness is a form of trauma and that a lot of things do come with homelessness, it's crucial. So we do need to be aware of triggers. We need to be aware of, the way that we talk to folks. We need to be aware of how we do say things. And I think a lot of individuals, especially if they have a traumatic brain injury, there's a lot of behaviors that are going to feel explosive to people working in this line of work. Just being aware of that, being able to de-escalate verbally, I think building that relationship is going to really bring you to the place that you want to be. It's going to kind of lead you down the path you want to. One of the examples I have from a personal experience that we had here in Fargo was we had a long-term shelter guest that moved into housing. He'd been at the shelter for a handful of years, and he had his routine. He was a wonderful dude. So he'd leave the shelter at the same time every day. He would go and get breakfast at the same place. He would take the same route to go to his lunch spot. He would go to the same liquor store to buy his 2 same beers that he had every day, and then he would come back to the shelter at the same time every single day. Well, once he got into housing, that routine didn't stop. That was something that was the structure for him that he needed, that made him feel like, okay, I can go about my life the way I want to. In homelessness at times, all the time, there's a stigma of, either the way people look, or there's going to be certain biases from people saying, well, why don't you just get a job kind of thing, right? Well, this gentleman, he had very long matted hair. In the 4.5 years I knew him, I'd never knew him to get a haircut. He had probably 10 dreadlocks that turned into one big old dreadlock, and it was pretty gnarly, right? So we had staff go over and do some housing supports with him, and they said, hey, what's the next step for you? And he said, I kind of want to get back into going to work. Okay, cool. What do we have to do that? And he's like, well, I need to fix my appearance. All right, cool. Let's bring you over to the barber college. It's an $8 haircut. We can get your hair put together. We can get everything that you need to feel good in yourself. Well, he wasn't comfortable doing that. He didn't want the people at the barbershop to look down on him. He felt ashamed in the way he looked. Before his homelessness, he was a rock star kind of guy. He was a musician. He played a lot of instruments. He sang a ton. Whenever we do karaoke night over at the shelter, he was kind of that rock star. And so what we did, instead of him feeling ashamed and bringing him into a situation where he wasn't comfortable, we actually just had staff pick up a clippers, go over there, and if he was comfortable with it, we cut his hair for him. And it was crazy kind of the change that we saw as the hair was falling onto the floor. His apartment was a little messy before. He kind of had his routine that he was stuck in when he was living in the shelter, but as soon as he got that haircut, he was back to his normal self. He lit up. He wanted to work on getting some benefits in place. He wanted, hey, maybe we can clean my apartment. And it was crazy how to see that just that little bit of getting somebody's haircut after years of building a relationship with them can put them in the position that they want to be in life, right? It's not up to me to decide, well, I think that you should go and be a welder. That's not up to me. He was comfortable and happy in where he was. And that's the big thing about meeting people where they're at, is not deciding for them what they need. To move kind of into some of the SSP work side of meeting people where they're at, I think we do need to acknowledge that people who use drugs have been stigmatized for a very long time. As far as any of us can remember, people who use drugs have always been looked on in a different way. I think acknowledging that the stigma with people who use drugs is deeply rooted in racism and classism. If you think of some of the poor communities in the country, those are some of the places with the highest levels of substance use disorder. And being able to notice that and being able to kind of work through that in your own self is going to be able to is going to help you get to the place you want to be where you're meeting people where they're at. The public health approach to the opioid epidemic here in North Dakota, we did open up 5 SSPs. I don't know if that was touched on before at all. I do apologize, but we do have 5 of them here in North Dakota. All of them, as far as I'm concerned, do very good work. We all strive to meet people where they're at and to provide the best service we can for people who use drugs at any point in their recovery journey. And knowing that sobriety is a personal choice for somebody, not pushing sobriety on somebody, that can ruin the relationship you have with them. And some people just don't want to get sober. And it's not my place to tell them, well, I think you need to get sober. It's my place in my role to make sure that they're as safe as they can possibly be when doing the things that they're doing. I say all the time to folks, one of the things we ask in our intakes is, have you gone to treatment in the past year? And if they tell me no, I say, well, are you comfortable discussing treatment options today? And well, I don't know, about 50% of the time I hear no. Well, I just let them know, hey, I'm here when you need me. And if you don't need me, well, now you know where to find me anyway. And I think leaving that door open, letting people make that personal choice of, okay, I know this is just a normal guy doing a job. He cares about us. And if I do get to that point where I'm ready to go to treatment, whether it's inpatient, outpatient, whether I need to get out of town, I just need to completely get away from my surroundings to feel better in myself, then that's what it is. And I think talking about where they are in their recovery journey and making a plan for that is really big. I see a lot of people on a day-to-day basis that maybe maybe are not ready to get sober today, but they know, hey, I know I got court in a month, so I can have fun for a couple days, but I know that I'm going to need to buckle down here soon and really take care of what I need to take care of, or this isn't going to go the way I want it to go. So I have an example of meeting people where they're at as far as SSP work goes. So we have a guy, obviously this isn't his real name, but Tommy's been using meth for 12 years. And as of late, the guy that he's been getting his stuff from, there's been fentanyl in it, right? So when he comes in and he tells this to me, we built a relationship enough where he feels like he can be open and honest about the product he is buying and the things that he's worried about when using his drugs. So the things we talked about, fentanyl testing strips. If you're really worried about it, we can get you some fentanyl testing strips. We can show you how to use them and make sure to test your products before you do use it. Another thing we touch on, especially with opioids and with fentanyl being in our state the way it is Narcan. Have Narcan on you. Make sure the people around you are carrying Narcan. Have a usage plan. If you are going to be by yourself, there are avenues you can take. There's Never Use Alone phone line. There's the Brave app you can use, where it's literally you press a button right before you use, and after 5, 10, 15 minutes, you press the button again. And if you don't press that button after that, they send emergency services to your place. So I think having a plan when you're going to use has a lot to do with the bodily autonomy of folks, right? It's not our decision. We're just here to help. Having those conversations can lead to, is this person ready to modify their behaviors? If they've been using stimulants for 12 years and they're starting to feel that the product they're getting isn't what they used to have, maybe using a little bit less, maybe utilizing fentanyl testing strips and having people around them that are trained in Narcan and naloxone can literally save somebody's life. A big thing is, I think when people seem open to change, don't push it all the way. Don't go scorched earth on them. Let the participant decide when they're ready, and when they are ready, lend them a helping hand. I think the internal bias for a lot of folks, once you can acknowledge that that this is a person's choice, they know what they're getting into. I provide the tools that I can provide. I let them know, hey, this is a scary game that's being played right now. This isn't what you think it is. 20 years ago, it was a lot different than it is today. And just giving people the information that they need and making sure that they understand it and they're comfortable in their usage can go a very long way. Another little example I have is a guy named Joe, right? So Joe is in a chaotic stage of his usage. Joe has been using for a long time. If you're in Fargo, you might have met Joe before. He is a pretty visible guy, especially downtown. Joe, thousands of dollars worth of damage to city property just because of substance use and kind of just not understanding the parameters in which, maybe I can't flush 8 pairs of socks down the toilet. Maybe I shouldn't put XYZ in the sharp container. What we learned was we weren't really getting anywhere with them. It was kind of the cycle of usage and the chaotic stages of usage. And we realized, he's running into law enforcement multiple times He's in and out of jail. And he's not getting the help he needs anywhere. So what we decided here at our SSP to do was we created a little tool, right? I know that if Joe comes in and he asks for 4 bags of syringes, that's 40 syringes. I know for a fact Joe's not going to bring me back 40 syringes. So what can we do to keep him safe in the moment? We know he's going to use anyway, right? So I don't want him to use a dirty syringe. He doesn't want to use a used syringe anyway. So what we did is we made a safer use kit. So that's 2 syringes, it's tourniquets, it's alcohol swabs, it's cotton, a little bit of everything that you would need, cookers, a little bit of everything that you would need in that moment if you're going to use regardless. And we know that we're not going to get the supplies back. Well, we don't want 38 syringes sitting down on the streets of downtown Fargo, but we know this guy's going to use. So we created a little tool for people specifically like him. And this gentleman wakes up one day in detox and he's in a very lucid state. A lot of the stuff he talks about is very, very typical to stimulant use, grandiose delusions, a lot of paranoia. I'm sure he has some underlying mental health stuff, but that day he woke up and he let us know why he got high as much as he does. And it was because there was a very traumatic experience for him right when he became an adult that really shaped kind of how he thinks and how he goes about life. And just building that relationship and having him tell us these kind of things, it was a little bit easier for us to kind of move forward. You know, for the longest time, a lot of staff were just thinking, well, this guy just doesn't get it. He's just wrecking things to wreck things. And it's like, well, no, he has some unresolved trauma and he's grieving still 20 years later. And if we can't get to the root causes of this and we can't talk through it with him, we're never going to get to a place where he feels like he can live a productive life. So that's just a little bit of stuff as far as meeting people where they're at when it comes to street outreach, when it comes to housing supports, when it comes to SSP work. So in conclusion, meeting someone where they're at means accepting them for who they are and where they are in life. Sometimes all a person needs is someone to hold their hand and walk with them to a better place, right? 4 things that everyone can learn to make sure they're doing what they're supposed to do when it comes to meeting people where they're at. Listen. Being aware of your preconceived biases or the way you think things should be. Don't be judgmental. Being judgmental when talking to participants, clients, whatever your organization calls them, it typically just puts up walls, puts up more barriers. So if you can just be open-minded about all the situations that you come across, you're gonna have a better opportunity to reach the people you want to reach, and then accept feelings and let people know that it's okay to feel the way that you feel. But let's work through this together, right? If you're sad, that's okay to be sad. If you're mad, that's okay to be mad. But at the end of the day, we can work through this. We can get you in a place that you'd like to be. That'll kind of conclude my little portion of it.
So Jordan, I was going to ask, since you're involved some with it, can you talk about the Downtown Engagement Center in Fargo? I think that would be something beneficial for the group to kind of learn about and how that even came to be and what's available there.
Yeah, absolutely. So the Downtown Engagement Center originally started as the quarantine and isolation unit for the transit community here in Fargo. When COVID first hit, we realized that there was, I mean, if you're living on the street, obviously you don't have a place to safely quarantine and you don't want a bunch of sick people walking around Fargo. So we were able to get our hands on a building in downtown. We retrofitted a little bit. It was the former police station, actually. So it was in a really good location. The building was great. We just needed to change a few things to be able to help folks isolate and try to stop the spread, right? That's what we were all trying to do. So that was the beginning of 2020. We served a lot of people during that time. And then when COVID slowly started to kind of taper its way down, we decided to turn it into the Downtown Engagement Center. This is something that's been talked about for probably 30 years and something that Fargo has needed for probably just as long. Excuse me. I think that if you think about downtown historically, right, that's where all the services are. So the libraries are typically downtown, the bus stations are typically downtown, Salvation Armies. When someone, especially in the transient community, gets into a new area, the first place they usually go is downtown. They're going to see people that might look like them. They're going to see people that are trying to utilize the same services as them. So we thought, what a better place than the downtown police station in Fargo. What we provide there, we provide a plethora of things. So we have showers, we have laundry, there's a homeless health clinic upstairs, there's connections to housing with Presentation Partners in Housing. So we really strive to be that one-stop shop for the transit community, or even the newly housed community, or really anyone that's precariously housed, to be able to come in and have some actual social engagement in the community that they live in. We've seen great results. We see over 100 people a day on average currently. A lot of times folks will come in, maybe even it's just for a group. A couple weeks ago, we had Tai Chi, and believe it or not, that was widely accepted. We had a room full of people just doing Tai Chi. It was kind of crazy to see, but I think being there, being able to engage with folks, and that is one of those things, meeting people where they're at. Well, a lot of folks are downtown. Well, let's go downtown, right? We had a building there, we retrofitted it, and we provided all the services that folks could need, referrals for treatment, referrals for benefits, whatever it may be.
Great, thank you. I had just recently learned about the deck, so it was great. So I was like, hey, I'll ask Jordan about it. So it's a wonderful service in Fargo. So we have some questions in the chat. So one for Jody and then one for Jordan. Jordan, can you please address the argument that the support services may equate to enabling? What would you say about this? And do you receive negative and positive feedback?
Oh, yes. So I hear a lot that we're just enabling. The way that I see it is I'm enabling people to take control of their lives. I'm enabling people to take control of their health, and I'm enabling folks to get a second chance. People can say that providing syringes is enabling, which that's your right to feel that way. But what's the flip side of it, right? If we don't do it, then we have higher rates of HIV and Hep C. We have higher rates of other communicable diseases that people get while injecting drugs, and the injuries that come along with it. So what we've seen here at our SSP is that providing something as simple as a clean syringe for somebody that's going to use anyway and has used for many years has led to way more referrals to services and way more connections to services. We see great results in the things we do. I get calls. I had a call, it was probably last year, a gentleman found a fentanyl testing strip on the street, right under a bridge. And he called us and he gave us the what for. Well, I explained what we do. It's not just giving out needles to junkies under the bridge. What we do is we connect people to services. We do HIV and Hep C testing, gave him the whole spiel. And by the end of the conversation, his response was, wow, man, I didn't know you guys were doing all that stuff. Well, thank you so much. Keep up the good work. So I think if you do have that feeling that, hey, maybe we're just enabling people, stop by one of the SSPs, talk to the people that are working in it. Really try to immerse yourself in the situation so you can understand and have an open mind. This is handful of years ago, it might have been a crazy idea, but we have CDC talking about harm reduction. We have the White House talking about harm reduction. It must not be that crazy if the feds are talking about it.
Great, thank you. So another question, I guess this could be both but it specifically says Jody. Jody, you mentioned providing phones to clients. Can you talk about how you do this? And also wondering if something is available through behavioral health or other agencies. So somebody asking about phones for clients.
Okay. A lot of times we get donations here at Custer Health, so they will bring old phones in so they can be repurposed. So that's one way that we get phones. And then through our Face It Together program, they have been working on getting clients phones also. They said that's one of their biggest asks is to get a phone. So I believe they're track phones. Don't quote me on that, but I do think that that's how it's like a flip phone type thing. So I believe that they are a track phone that they provide for our clients.
Jordan, thank you so much. And Jody as well. And I had asked this question of Jody before we were able to have you join us. And how are people finding out about your SSP? When Jody answered the question, it was they do a lot of social media, and then but it's a lot of word of mouth. So I was just curious how you get yours. And then I had one other question too, Rebecca.
Yeah, so I would have to pair it what Jody said. We do a ton on social media and we have a huge reach. I think a lot of the folks that we reach on social media aren't typically the people that will utilize our SSP. So we do rely on word of mouth quite a bit. But to get the folks to speak well about your program, you have to provide good services, right? So you have to be able to have the conversations that people want to have, and you have to be able to build those relationships. Otherwise, no one's going to come through your door. But yeah, just like Jody said, a lot of word of mouth. We do a lot of social media stuff as well. So
awesome, thanks. And then my follow-up question is kind of off of what Jody put in about her SSP, that they did work to open, in a small rural community in North Dakota, but they didn't see it being utilized. And so then they needed to close it, and they felt like maybe it wasn't being utilized due to lack of privacy in such a small rural community. I'm curious if there's anyone on the call here that has a successful SSP in a rural community in North Dakota, or if there's maybe some tips or tricks or things that maybe our smaller communities could utilize to not maybe necessarily open one, but let others know about where there are SSPs. So just curious from the group if there was anybody had some brainstorming ideas, and maybe Jody and Jordan, maybe you can get us started off if everybody else is crickets, because maybe that's a hard question.
I can jump in quickly. I think one of the big things for folks that are going to utilize services in the SSP is the location of the building. So we're lucky enough to where we are downtown, but we're tucked away. If you don't know where we are, you wouldn't know where we are. And I think a lot of people like that. We're right by the train tracks, right under the water tower. So I think not having to, go into maybe a county building or like a nursing clinic or something like that, I think that really benefits us. As far as the privacy thing goes, I think just ensuring folks, I tell people all the time, everything we do is discreet and everything we do is confidential. The codes that we give out, I'm assuming a lot of them are the same around the state. The mom's first initial, your first initial, and then your full birthday. I have people say, well, I just gave you all that information. I tell them, yeah, but I don't know if that's true. You could tell me your name is Mickey Mouse, and for all I know, right? I have no way to prove this. I'm not going to ask you for an identification or anything like that. And I think that assurance, they're like, okay, yeah, you're right. I could have just made all this up and you'd have no idea. So that's worked for us. I don't know if Jody, the same thing for her organization.
Yeah, we use the same type of ID type thing. One thing with the small communities, I know we looked at changing our site in Beulah, but talking to the chief of police, and he was all for our syringe exchange program, but everything was either too close to a school. I mean, when you're in a small community, there's not a lot of places to hold syringe exchange. So we just could not find another site in Beulah that would work, that wouldn't cause issues. So, we hoped it would work, but not one in Rowley in that community. And where we're located here, we are located in a strip mall. Like I said, we're next to a bar. We're a public health agency, but we are kind of cleverly hidden also.